Hey everyone, it's Dr. Wood. If you can hear me, let me know. Going for you this morning. Perfect. All right. Let's see. We'll get started in just a few minutes. All right. Very good. Things will look a little different this week. I'll explain that in a few minutes. But and again, if you have any questions in the meantime, feel free to post them up. Either here on the sticky board, one are fine. We got about half the class in so far, so that's a good start. Hope everyone's having a good week so far. My other classes actually just started this week. You guys are a little bit ahead of the game. How did the tutoring session go? Did that go okay? Your second year grad assistant friend? Well, it's almost time, so I think I'm gonna go ahead and get started here. So, let's see. It's good she set up a Zoom meeting. Oh, that's good. Yeah, because I figured she'd be out on rotation since she's out on second year, but good. And she's gone through it, so she knows kind of what she's talking about. But all right, so I'm starting the recording here. Let's see. So if things look or sound differently, that is because I'm actually not in Florida this week. Unfortunately, we had a death in the family, so I am actually up in an Airbnb in Georgia, and so I'm kind of on my mobile setup. So I'm having to try to, change a few things around here a little bit to make sure that I can still come live to you guys and it'll give you a pretty good experience here. So anyway though, and if you hear children, oh thank you, yeah, not on my side of the family, but still had to make the drive up and to make sure we take care of stuff. But and I look a little dark, and I'm trying to get as much natural light in here, but that's because it is quite overcast in Georgia. So hopefully the power and the internet will stay up, but things go down. I'm recording this anyway, so I can post that up later if something goes catastrophically wrong, but we will hope against that. Anywho, I got some questions here. So first off, do we need? Oh, and I apologize if you hear screaming children in the background. That's thin walls in the house, but it is what it is. So first question here, do we need to do anything with the Respondus Lockdown browser after downloading it to our computers for the assignment? You will use that for all of your exams, whether you're on campus or off. We're using Lockdown browser. You have to have a webcam available and all of that to take your exam. So yes, that's just what you're going to do with the Lockdown browser. Up next, okay, Dr. Wood, I know last lecture you mentioned exams will be on Wednesdays, but I just wanted to confirm the dates of the 3 exams. Yeah, I apologize. I need to update that syllabus with 2020. You get caught up in some of the grander details of a syllabus and you forget the little stuff like changing the year around. But yeah, it'll be on Wednesday for all of those dates, and I can update that. So thanks for keeping me detail oriented from that standpoint. Hi, Dr. Wood. Can we please go over question 8 on quiz 1 briefly? The question was drug A is dosed at 100 milligrams daily to lower blood pressure by 15%, and drug B is dosed at 10 milligrams daily to lower blood pressure by 15%. Yeah, so when you're looking at doses like that, remember you're kind of comparing their relative potency to one another in terms of how much effect you're getting. So when you're looking at two doses that are different for different drugs, so in this case here 100 milligrams of one and 10 milligrams of the other, if they're getting the same effect, that means that they're equipotent, right? So if I were to say have a patient getting 5 milligrams of IV morphine, and I could get the same effect out of that in terms of analgesia as if I were to give 100 micrograms of fentanyl, right? So between those two, those would be equipotent dosages, even though they're quite different. 5 milligrams to 100 micrograms is a huge difference, but they're equipotent because they get the same dose, or the same effect out of that. On that same note, though, I can't say anything about the relative efficacy, the max efficacy between those two. I can't really say anything about safety off of that. You're just really saying that those are equipotent doses there, right? And I do that all the time when we're trying to sub out one drug for another. Like, say, for instance, if we go on shortage of one drug and we have to switch to a different drug in that same therapeutic class, you have to do equipotent dosages to make sure the patient gets the same effect, right? So a good example of that is with the drug ranitidine or Zantac, the common drug used in the hospital to treat GERD symptoms and prevent stress ulcers, and it got taken off the market. We've been using it for decades and got removed, and so because of that we had to switch over to a drug in the same class called famotidine, Pepcid being the brand name, and we had to find equipotent dosages in order to make sure the patients got the same effect, even though they're using a totally different drug. Hopefully that makes some sense. Hello, Professor. When it comes to the Henderson-Hasselbalch equation to be permeable, should the ratio of non-protonated to protonated be large or small? So you want to, that's a good question, right? And so you kind of are focusing on almost not the right aspect of it. You got most of it though. So when you're looking at a species, whether it being protonated versus non-protonated, you want to take that into context of it's a weak acid or a weak base, right? So you need to consider, in each of those situations, what does that mean for it? So in the case of a weak acid, if you protonate that, it goes into the unionized state, right? Because it has an extra proton, so it cancels out that negative charge that the acid has by itself. So in that case, it would increase absorption because it's in a in a less polar state. It's kind of an easier time crossing over. On the flip side, so in that case, you'd want to have a large ratio of protonated versus non-protonated to increase absorption. On the flip side, if you had a weak base, you don't want to protonate that because that puts a positive charge on it. Two positives together, or a neutral plus a positive makes it a positive molecule. So in that case there, you're actually increasing how polar it is. You're going to end up causing a decrease in absorption, right? So that's the thing you want to focus on there. In the case of a weak base, you'd want to have a high ratio of the unprotonated species in order to allow it to cross over. Yeah, I'll talk about that in just 1 second, Kalash. Hopefully I said that correctly. Okay, so it says, in question about the therapeutic index, slide 118 graph looks like the TI is a space between the ED50 and the TD50. However, the writing on the slide looks like the TI is from the ED50 and LD50. Can you explain the concept more and how it relates to the margin of safety? Yeah, so basically when you're talking about a therapeutic index, you can kind of either focus it on the TD50 or the LD50, both of which are going to be in a ratio with the denominator being the ED50, right? So you can kind of define what that is. So I could say, for instance, if I was to use the drug Benadryl, right? Benadryl, diphenhydramine is generic, use it for allergies all the time. One of the common side effects is sedation. So in that case there, I could use the ED50 of the dose needed to decrease allergies or allergic symptoms versus the, say, the TD50 of causing sedation, right? I could figure out what the therapeutic index is between those, and that would actually be pretty narrow because most people do get sedated while taking Benadryl, right? On the other hand, though, I could set up a TD50 of, say, seizures, right? And that would be much farther out because I would need to have a much higher dose in order to cause that seizure in that case there. So when you're looking at that specific toxicity, that's what you're looking at. Although I could also look at the LD50, which hopefully is even way further out, hopefully you'd have a very wide therapeutic index in terms of looking at the LD50, because you don't want someone to take a double dose of Benadryl and then have a high risk of dying, right? That would not be a very good drug or very safe drug in those instances. Do we have drugs like that where even small increases in dose can lead to possibly death? There's not many, but in maybe some chemotherapeutic drugs or something, but it can happen. So it's really all in how you define this. Okay, so Kalash was saying, can you explain the difference between medicine tolerance and resistance? Yeah, so tolerance means when you're giving a medication and basically you give the same dose to the patient over a long period of time, let's say months, for instance, and you start to notice that the drug's effects start to get lower and lower and lower. So I give a patient an antihypertensive, and initially their systolic blood pressure goes down 15%, right? And then over time, you then start to notice it creeping up to like maybe a 10% reduction, then a 5% reduction, and maybe it even gets back to baseline. That would be considered tolerance to the medication. In order to overcome that, I could then increase the dose to get around that. Now, why does that patient become tolerant to that? Well, part of it is due to resistance, right? It could be due to resistance of the body to those changes in systolic blood pressure. One thing you'll learn about hypertension is the fact that the body resists change, right? It likes homeostasis, it likes the status quo. And for someone who has hypertension, where a normal blood pressure would be 120 over 80, maybe they're now used to having 180 over 100. That's just their normal now. So when you try to change that, if you try to lower that, the body's going to resist that. And it can do that in a number of ways, which we'll talk about later on. I don't want to belabor the points here. But you get the idea, is that resistance is a process in order to cause that tolerance to occur, in some cases of which I can increase that dose to overcome that. Sometimes, though, you have what we mentioned, that tachyphylaxis, where even if I keep increasing the dose, I don't get any additional effect. And that part of it has to do with a different mechanism, and you have to withdraw the drug, give the patient a chance to sort of get back down to baseline, and then you can reinstitute it, and you should get those effects back, right? So you should be able to get kind of back to the baseline sort of effects. We mentioned nitroglycerin in that case there. So hopefully that makes some sense. I'm going to switch back over to the PowerPoint, and we'll finish up this section and get into the week's 3 content. So anyway, so I think we finished off with elimination last time. We're starting up with this. We mentioned metabolism, and we were going over all of that in terms of CYP enzymes and different metabolic pathways. Now let's get into the last portion of kinetics and how you actually get rid of the drugs overall. And so basically here we're going to see that drug elimination is going to primarily occur through 2 places, the lion's share of which is going to occur through renal elimination through the kidneys. We'll also have some drugs that actually go out through the biliary tract, meaning they get spit out through the liver into the biliary tract into the intestines, where they can then be eliminated in the stool. Those are the 2 main things you're going to see there. And again, what you're going to find is, and we'll mainly focus on the actual excretion from the kidneys, what we're going to find is that this is going to be based off of the drug being filtered through the glomerulus. So hopefully remember your renal physiology there. We'll filter the drug through the glomerulus, and then in some cases it may actually be reabsorbed back into the body, or in some cases we may have transporters that actually help to excrete the drug into the renal tubules, right? And the reason why that may occur has actually to go back to that Henderson-Hasselbalch that we talked about before on the charge of the drug. And so you can see here that just like the changes in the pH of the GI tract can cause changes in the ionization state of a drug, you can see even greater, well, maybe not greater shifts, but you can also see a range of pHs here in the urine, which can go anywhere between relatively acidic 4.5 all the way up to 8. Remember that in terms of acid-base status, like the kidneys are really important for helping to maintain that in the body, because it can regulate how much bicarb is either being eliminated or reabsorbed in a lot of cases, right? So kidneys are very important from that standpoint. Lungs important for acid-base status. Kidneys also more important for more long-term sort of control there, right? So what we're going to find is that based on that ionization state of the drug, you can actually change how well it's going to be reabsorbed or eliminated. So for instance, if I were to have, say for instance, let's say we wanted to, I can't really draw right at this moment, but if you were to have something kind of cross through that glomerulus and into that renal tubule, if it's in a state where it's able to be absorbed pretty easily, so it's in a non-charged state, it can actually be reabsorbed back into the system. And so that's why you may actually find that drugs have a longer half-life if they're being reabsorbed after being filtered through the kidneys there. And so we can actually change that, though. We can actually find that by changing the pH of the urine, you can have an effect on how quickly drugs get eliminated. And that also goes into how we can actually trap certain drugs in certain areas of the body. I think I mentioned breast milk last time, where you can actually have that change in pH from the blood, which is normally like 7.45 to 7.55, or something like 7.4 is usually a normal blood pH. Can you go into another compartment like the breast milk or like the stomach, you can actually trap drugs there in some cases. And so the urine can be seen as sort of the same thing, where you can actually have drugs being trapped out in the urine, which actually helps to enhance their elimination. So actually I do that pretty frequently. If I have someone who has, say, they have overdosed on a weak acid like aspirin, I can actually give them something to alkalize the urine to increase the pH of it, to cause the weak acid to be in a very highly ionized state, and that prevents it from being reabsorbed, and they actually eliminate it faster. So I can actually alter that by how I change the pH of the patient's urine, for instance. So, but overall, when we're looking at clearance, this is basically looking at the amount of blood being cleared of drug per unit of time, right? So it's actually how much blood you're actually clearing of all that drug that's there. And you're going to see that this can be a combination of, liver clearance, renal clearance, and all this, but we're just going to basically lump it all together and mainly focus on the renal clearance for our purposes here, since most drugs do undergo renal elimination for the most part. And this is going to be quite important for determining drug concentrations, because if I'm not clearing a drug, if I'm not eliminating it from the body, then that means it's sticking around for longer, which means I'm going to have higher concentrations, right? So clearance is going to be really, really important in order to determine how quickly we're getting rid of drugs. And so, if I have someone who has bad kidney function, they tend to hold on to drugs more frequently, and that means I have to change how I'm dosing it, whether I'm giving less drug or I'm giving it less frequently, to make sure they don't have levels build up to the point where they actually get toxic from it. So how do we determine how good a patient's kidneys are functioning? Well, that actually goes back to estimating what their creatinine clearance is and looking at their GFR, right? So GFR stands for glomerular filtration rate. It's a hard word to say. And that's basically how much filtration is happening at the glomerulus, right? It's pretty straightforward. Well, we don't have a really good way to directly estimate that in a patient. So what do we do instead? Well, we use what we call serum creatinine. And if you ever look at like a basic metabolic panel, you'll see these all the time. And essentially what we can do is use how well patients are clearing creatinine from the blood in order to determine how well the patient's glomerulus are filtering drugs, right? We're using it kind of as a surrogate marker here. So what is creatinine? Well, creatinine is a byproduct of muscle breakdown, right? And you're generally making it at a pretty constant rate that is then cleared by the kidneys. Now, are there situations where that can change? For sure, right? You can have patients who have very low muscle mass where they don't produce a lot of it, or perhaps they have a lot of muscle breakdown where they're making a ton of it. But let's say for normal patients, you're going to have a pretty consistent amount being made there. And usual serum creatinine, which is what we measure on our, our Chem7s and our CMPs and all of that, is going to be a plasma concentration of between 0.6 and then 1.2 milligrams per deciliter. That's considered to be pretty normal, right? Now, that can change wildly depending on the type of patient, which I'll mention here in just a little bit. And ideally, what you could actually do is you could actually take a patient, give them a big bucket, and say, here, collect all of your urine for 24 hours, and we can measure all of that creatinine that's in there, get the concentration of it, and determine how much creatinine you've cleared in 24 hours. But most patients don't like to carry around a bucket of their urine, so you're not going to find too many people that are going to want to buy into that. But what we can then do instead is use that serum creatinine as a marker of how well their kidneys are clearing that creatinine, and then we use that as a surrogate for the GFR. It sounds complicated, but let me explain. So if a patient has poor kidneys and they're not filtering things like they should be, then they're going to hold on to things in a higher proportion, right? So for instance, with creatinine, if a normal value is 0.6 to 1.2 and a patient has their kidneys shut down all of a sudden, then you would expect that to go up, right? Because of the fact that the patient can't clear it very well. You may find patients with a creatinine 2, 2.5, 3, and in some cases patients with total renal failure who maybe are not, they're missing their dialysis sessions, they can get to 5, 6, 7 milligrams per deciliter, get quite high. So if a patient's kidneys are functioning well, then they're filtering that creatinine, getting rid of it, and you should have a normal level of that 0.6 to 1.2, right? Well, you also have to take into account some other factors as well, such as like the patient's age, right? That may have an effect on overall how well their kidneys are functioning, right? So older adults, they probably have worse functioning kidneys than younger adults, for instance. We also want to look at their weight as well, because a larger patient presumably has more muscle mass than a smaller patient. And then we're also going to look at their creatinine additionally. So this is the Cockcroft-Gault equation. This is the most common one we use for drug dosing purposes to see if we need to adjust that. So if you ever look up a drug on, Lexicomp or Hippocrates or whatever reference you use, you will find that there's a section generally for how to adjust drug dosing based on lowered renal function. And this is what we're using here, is this Cockcroft-Gault. So this applies to most adult patients. And so I'm not going to have you calculate this, but I want you to notice the variables that are included here, so you have an idea of how these change in patients and how it has an effect on their serum creatinine, right? So looking at this, creatinine clearance is equal to 140 minus the age, right? So this is the first portion here. So the larger their age is, the smaller this number is going to be, which means my numerator is smaller, which means my creatinine clearance is smaller. So a patient who is 20 is going to have a much larger value here than someone who is 80. Right? What that means is that someone who is 80 probably doesn't have as good a kidneys as a 20-year-old, right? Now, there's some exceptions for sure, but that's not the general case. So you can see here, age is going to be a factor. Weight is also a factor, where if the weight is going up, you generally have more muscle mass, you're producing more creatinine. This also should have a relative increase in creatinine clearance as well, which will be offset by the actual serum creatinine value we'll see here in just a moment. Now you may ask, well, what if you have a patient who is like 500 pounds in the ICU with respiratory failure? Are they really packing all that muscle? Chance is no, right? And there are some ways we can actually adjust this based on obesity. You have to consider though that these a lot of these formulas and things were made back in the 50s when obesity was at a much lower incidence, and so it is what it is. But we find some ways to get around this. So, but don't get too hung up on that right now. The big thing I want you to notice too is the fact that serum creatinine is going to be in the denominator here, right? So this means that the higher this value is, presumably the kidneys are not clearing it as well, the lower the creatinine clearance is going to be, okay? So if they're holding on to more creatinine, that means that the creatinine clearance is down. Versus if this is a lower number in the denominator, this means your creatinine clearance is going to go up, meaning they're clearing it better, so it's not there in the blood to even measure, right? Because it's the serum creatinine we're measuring, not a urine creatinine. And then there's a modification factor here, so like you multiply by 0.85 if the subject is female. In general, female patients are going to have a higher adipose tissue content than male patients, a little less muscle mass on a kilogram per kilogram basis. Does that always hold true? Absolutely not. But again, this is done at a certain time point, and it works reasonably well for our purposes, so we go ahead and stick with this. Just know that there's going to be other equations that are out there. This doesn't work for everything. For instance, for like elderly patients, like above 65, sometimes we'll use a different equation here, like this MDRD, the modification of diet and renal disease equation. And you can even notice here they actually factor in the patient's black or not, right? So I can also find maybe some genetic factors that play a role in terms of a patient's creatinine clearance, for instance. Okay. Notice here we haven't talked about children at all. There's specific equations just for kids because kids function much differently than adults, as we're going to see a little bit later on. So main point being is that none of these equations are perfect, but they generally are going to be taking in these accounts of patients' weights, their ages, and then creatinines in order to get an idea of how well they are clearing that. And if they are clearing creatinine well, then they should be clearing drugs well. Converse is also true. If they're not clearing creatinine, they're probably not clearing a lot of drugs, right? Not every drug, but many drugs, okay? So normal creatinine clearance is typically around 100 to 120, depending on whichever reference range you're looking at. This is generally what you're going to see here in terms of normal. Again, I'm not going to ask you on a test what a normal creatinine clearance is, but just to get you sort of acclimated and sort of looking at what normal values should generally be, right? Okay, so going back to why do we care about this? Well, because when you're looking at clearance, and then you're also looking at the volume of distribution, which if you recall, is how well drugs are being distributed out into the tissues versus how much they're being sequestered in that central circulation there in the plasma. That determines half-life. This is an important point. Clearance and volume of distribution determine the half-life. What is half-life, you ask? Well, that's how long it takes us to clear out 50% of the drug in the body, right? So once that half-life is elapsed, you now have 50% of whatever you had to start with at the beginning of that half-life, which is important because drugs can have their half-lives change depending on things like creatinine clearance or depending on the volume of distribution here, right? I can show you why that actually happens here. So clearance, as I mentioned, is determining the amount of drug being eliminated from the blood per unit of time, and that volume of distribution determines how much volume needs to be cleared, right? So you can have drugs that have a low volume of distribution that for a patient may only have, say, like 50 liters to be cleared, It's a lot easier than if it was, say, 200 liters that need to be cleared, okay? 200 is going to take a lot longer than 50 liters in this case. So the higher the volume of distribution, you're going to see that actually helps to extend the half-life, and then clearance is also going to have a proportional effect on that as well. And again, why do we care about that? Because based on the half-life, that helps us to determine our steady state plasma levels. I'm going to get into that into more detail. So how are drugs eliminated from the body? There's two main ways this occurs. There's first order elimination and then zero order elimination. Another name for zero order is capacity limited. The majority of drugs are going to follow first order elimination, and that's what I'm going to focus the most on. Basically, and I'll show you with some graphs and this will make more sense. First order elimination is that you're eliminating a constant percentage of drug per unit of time. Okay, that'd be 10%, 15% per hour, 100% per hour, whatever the case may be. You're eliminating always a constant percentage, which means that if there's more drug in the system, I'm also eliminating more of that drug. Okay, it's always proportional to the concentration. Most drugs are going to follow this. Zero order is less common. You're going to find this is generally when you kind of oversaturate, enzymes to metabolize a drug, or you've oversaturated some portion of the process here, where instead of metabolizing a constant percentage, it's a constant amount of drug per unit of time, which means it's basically independent of concentration. So I always like to use the example of ethanol here. Ethanol very easily overwhelms a lot of the metabolizing enzymes in the liver. It means you only will be metabolizing on average about 20 milligrams per deciliter per hour. Well, that equates to about 1 drink per hour. And so what's actually kind of convenient about this is if you have a patient who came into the ER, say police arrested them for being publicly intoxicated, they come in and they have a level of 100 milligrams per deciliter. Well, I can look at that patient and say, okay, well, I know that in 5 hours they're going to be at level 0 because I know that they're going to be metabolizing a constant amount of that drug per unit of time. So 20 milligrams per deciliter per hour. If their level is 100, 100 divided by 20 is 5. Boom, I know it's going to be 5 hours for them to eliminate that drug. It's more complicated with first order elimination, but we're going to see this is also going to be how we look at most drugs because most drugs follow this, right? And if you were to look at clearance of drugs, as a form of concentration on the y-axis and their time on the x-axis here, you would see that with zero order it would be just a straight line down because it's always a constant amount of drug per unit of time here. Whereas with first order, what's interesting is that the higher the concentration, you're going to see here that you're actually metabolizing more drug. Even though it's always the same percentage, you're going to see here that at very high levels you're metabolizing a lot of drug, because all being presented to the liver and to the kidneys to be eliminated. And then as you get to lower and lower levels, the metabolism actually slows down, right? And so this is going to be really important for many drugs in order to determine how we're going to be dosing it, how much we're going to give, how often we're going to give it, etc. So we're going to get into more details on that here in just a second. So we're going to see here that with first order elimination, renal clearance is going to be affecting a lot of this. And so what you can see here is that when we're looking at the concentration of the drug, we can also look at the rate of the drug administration. So how much drug I'm putting in is going to help us to determine the actual clearance here, right? So rate of administration can also be sort of equilibrated to, or can be the same as saying, well, how big of a dose I'm giving and how much of an interval I'm giving it, how many hours apart. So I'm giving 500 milligrams Q6 hours. This would be 500 milligrams here with the interval of 6 hours, right? And so I can look at how fast I'm putting it in. I can look at the concentration then and determine how quickly the body's clearing that, right? And so some patients or some students actually get caught up on this a little bit because they're like, okay, well, obviously if I increase the dose I'm giving the patient, clearance has to go up. Well, to a certain extent, because if I give more drug, I'm also going to be having a higher concentration as well. So these are going to be going up proportionally together as you increase one, but clearance should be relatively similar, okay? When I say clearance, I'm talking about that percentage of that drug you're metabolizing per unit of time, okay? So it's that proportional relationship. As drug amount goes in, concentration is also going to go up at the same rate. And so what that means is basically if you were to say put in, say you have a patient, you inject into them 1,000 milligrams of a drug, right? So you have time here, 0 hours, they have 1,000 milligrams. If this drug follows first order elimination, and let's say we're going to say after 1 hour, this drug has now gone down to 850 milligrams because we metabolized 150 milligrams here, right? This means that we have eliminated 15% of that drug during the hour, okay? What you notice is now that we have a lower amount of drug in the body here, we're still going to metabolize 15% of that, but if you notice here, the actual amount of drug we eliminated in that second hour has gone down. In the next hour, it goes down even further and further and further down, so such that you're still metabolizing 15%, but it's going to be less and less as that drug concentration, what's left in the body, has decreased as well. Okay, so there's always going to be this proportionality between the amount of drug in the system, the concentration, and how much clearance is happening there. And so what you can look at that another way is if you're looking at concentration on the y-axis and time and half-lives here, you can see that it follows this here, where if I have a higher concentration, I'm actually metabolizing a lot more drug, but you can notice here it's a very consistent half-life between all of these, right? Such that the time is always going to be the same as I have this each time. So as I go from 100% to 50, 25%, to 12.5%, to 6.25%, etc., on down the line until you have basically no drug left. Okay, so drugs follow this, and it's really important that they follow this because this allows us to get to a certain steady state level, as we're going to see here in just a moment. It's a really important concept that we'll get to. With alcohol, though, what's going to happen is even if I keep increasing the dose, ad infinitum, because it follows zero order kinetics, you don't really get the same sort of half-life thing, because you're always going to get that same 1 drink per hour sort of metabolism that occurs there. So let's look at some different factors that go into this, and let's look at what determines what our steady state is. So when looking at half-life, we can see that this is basically the time it takes for drug concentration to drop by half. And we do this all the time in the hospital, right? If a patient's on a really narrow therapeutic index drug, like an antibiotic, and we want to make sure that we're getting good enough levels to kill the bacteria, but not levels so high that we're causing harm to the patient there, we have to use drug levels to help us out and make sure we're getting patients treated just right? So basically, when we're looking at this, we have to determine what a drug's half-life is. And so you could do this as an example of looking at a drug and say the concentration at 4 p.m. is 20 mics per ml. And then, so let's say you did another level at 8 p.m. and it came back and the concentration is 10 mics per ml. Well, what you notice here is that the concentration has dropped by half, from 20 to 10. You notice that 4 hours have elapsed, so you might assume correctly that this is a 4-hour half-life. Pretty good sense. Most drugs are not going to be quite so simple as this. It gets more complicated, but for our illustrative purposes here, this is as bare bones as it gets. With drug B concentration, let's say you started with 40 mics per ml at 8 a.m., but then you went ahead and got a concentration of 10 mics per ml at 4 p.m. Okay, well, looking at this, it looks like you've had 2 half-lives occur, because you went from 40 mics per ml down to 20, which is 1 half-life, and then from 20 to 10, right? Notice there that you metabolized less drug, but it's still the same percentage of drug, right? Still 50% has been metabolized during that period of time. And if you go here from 8 to 4 p.m., 8 hours, you can still see here that it's still a 4-hour half-life, right? So I have 2 half-lives that have occurred over 8 hours, 8 divided by 2, 4-hour half-life. Okay, so it's the same actually between these, even though I have different concentrations, I've measured them at different times, these two would actually have the same half-life of 4 hours. Okay, you're like, why in the heck do I even care about this? Because half-lives can be really variable from drug to drug, and this has a huge effect on how we actually dose the drugs. So for instance, let's say we have a patient who is in the ER, their heart rate is like 160, they are in SVT, right? So supraventricular tachycardia, and we need to disrupt that, and we need to get the patient back in a normal sinus rhythm. A couple of different drugs we can use for that, but the half-lives of them can be quite different from one another. So for instance, here with the adenosine, half-life's about less than 10 seconds. It means if I were to give you 6 milligrams of adenosine in less than 10 seconds, how much is left? 3 milligrams. If I go another 10 seconds, now you got 1.5 milligrams left. So the drug degrades at an incredibly fast rate, which means that if I'm going to give it to the patient, I got to get it to the site of action as quickly as possible, right? Which means the heart, because they're in arrhythmia. So if I give that drug very slowly, say through a peripheral vein, say I'm going into a line on the arm, it's going to take a while for that to go through the venous flow back to the heart for it to work. If you don't push it very fast, that means that drug's not going to make it to the heart before it gets degraded, right? So you have to push that drug really super fast. So if you ever see someone give adenosine, they have to basically slam it and then give 10 mLs of saline behind it to flush it to get it to the heart fast enough for it to actually do its thing. Many people actually screw this up and don't give it quickly enough. On the other hand, though, let's say our adenosine is not working, we can switch over to another antiarrhythmic drug called amiodarone, which you can notice here. We use this for a variety of different arrhythmias, but it has a half-life of 26 to 107 days. That means it could take more than 3 months to eliminate 50% of that drug from the body. So extremely slow half-life, right? So it can range wildly depending on the drug that we're dealing with, and that has a huge effect on how we're actually going to be dosing these drugs, right? How often, what doses we're giving, all that sort of thing, okay? So what I want you to get down to is to how we actually calculate the half-life is we actually can figure this out based on the volume of distribution of the drug and the clearance. So if you look here, don't worry about this 0.693. This is just kind of a constant value that we use to determine this. But what you can see is that by modifying volume of distribution or clearance, you can have a drastic effect on the half-life, okay? So based off of this, if this is true, then what happens if I have a larger volume of distribution? Let's say I have a patient who has a hydrophilic drug in the system, but now all of a sudden they develop edema, right? Because they have all this extra body fluid sitting around, and that drug is then going to have a larger volume of distribution because it's going to distribute into all that extra water. Well, if I have a higher volume of distribution, that means I have a longer half-life, which means it takes longer to get rid of that drug, which means maybe I need to consider how I'm dosing it, otherwise levels are going to start to build up, and that may be a problem. Or what happens if clearance goes down, right? So let's say I have a patient who has a drug that is almost entirely eliminated from the kidneys, all of a sudden the kidneys just stop working, total kidney shutdown. Well, what would happen in that half-life? Well, clearance is now dropped like a rock in the denominator here. You're going to see half-life is going to then skyrocket, right? So the half-life is going to extend out quite large such that the patient can't get rid of that drug almost at all. Now, it's not generally that stark of a difference there, but you can see maybe you have a patient with, say, a 25% change in renal function or 50% change. That can occur quite often, and that will then extend out the half-life pretty drastically. So keep these relationships in mind in terms of how volume distribution and clearance have a role to play with the half-life of the drug, how fast we get rid of it. Because that then goes into our steady state. And what is steady state? Steady state is basically when the amount of drug you're putting into the system is going to be equal to the amount leaving the system. And so you should have a patient who has a relatively steady level of drug, a steady average level of drug in the body at all times, which hopefully is going to be at a point where it's therapeutic, but not so high where it's going to cause toxicity and harm to the patient, right? And so what we're going to find is that with the steady state, it's going to be based off of several of these variables that we've already looked at. So steady state, which is abbreviated CSS, or concentration at steady state, is going to be equal to the dose that we're giving divided by the clearance times the dosing interval. Okay? So based off of this, we can see that if we give a bigger dose, we're going to get a higher CSS. If I change my interval and say go from, say, every 4 hours I'm giving a drug to every 8 hours, I've now increased that interval and I made my denominator larger. It's going to cause steady state levels to go down. You're like, well, why are these things happening here? I'll explain in more detail. So basically, as I mentioned, dose is going to have an effect. If you lower dose, CSS goes down. If I increase dose, CSS goes up. If I change that interval, as I mentioned before, that can have an effect there as well. And then also, you have to think about the patient's clearance. So if the patient's clearance goes down, because their kidneys shut down, for instance, that's going to cause steady state levels also to rise. Right, and I'll show you some graphs so this makes a little more sense here in just a moment. And again, I apologize for all the squealing, but you know, kids are going to be kids. So another really important point here, and I want you to kind of highlight this and focus on this. It takes roughly 4 to 5 half-lives to get to steady state. Okay, this is really important because a lot of practitioners don't realize this, and they act on drug levels too soon because they don't give a chance for the body to get to steady state. But you gotta wait 4 to 5 half-lives. This may be a day, this may be a couple of days, depending on the drug, or in the case of amiodarone, we saw 107 days as a half-life. It could take 500 days for that drug to get to steady state, right? That's important because that may have an effect on how effective the drug is going to be as well. So let's say, for instance, that we're giving a drug here via continuous infusion. Sorry, I'm giving my children as they're leaving. I may hear them knock on the window. Hi. Anyway, so let's say we go in and we're giving a drug via continuous infusion. You can see this line here, this red line, is going to be the concentration of drug in the body. Let's say we're going to do a constant monitoring of the patient's plasma level. So as we increase, or as we're giving this continuous infusion of drug into the system, what you're going to notice here is going to rise, and then eventually it's going to hit this plateau point. What is this plateau point? This is the point at which the amount of drug I'm putting into the system is equal to the amount of drug that I'm eliminating from the system via clearance, such that I get this really steady level. And assuming that the clearance has stayed the same, assuming I give the same dose, right? So this infusion stays the same, I can leave that patient alone for a year, assuming no changes, and I come back, I'll get that same level, right? It's a steady state where I've hit this equilibrium point. So, and we can measure that, and that's that CSS we see here. And let's say I was to stop that infusion all of a sudden, then you would see a precipitous drop off here as the drug begins to be eliminated from the body. Okay, so this is what steady state sort of looks like if I were to do a continuous infusion. Now, is it common that we do continuous infusions in patients? Not really, because it's labor intensive. I can't send a patient home on continuous infusions. Generally, it's intensive from a nursing standpoint, things like that. So it's not common. So frequently, what we do is intermittent dosing, right? And so what you can see with intermittent dosing is that we are giving it intermittently, so every few hours or so. You can see that you get sort of a similar sort of picture. So this blue line here is going to be the continuous infusion sort of example. This is what the steady state would look like once I hit this plateau point here of giving a continuous infusion of a drug. But as I mentioned, we don't do that frequently, so instead what I can do is give a drug intermittently. So I give IV boluses of the drugs. I'm giving a bolus of a drug, say, every few half-lives or so. And so what you see here is you give a dose of the drug, it rises up, and then it starts to be eliminated, okay? Now I don't let that drug get all the way down to a level 0. Instead, I'm going to go ahead and dose the drug again. So I dose the drug again. And what you notice here, there's some dose stacking that occurs. There's drug left around from this first administration when I give the second dose of the drug, right? So I have some leftovers. I give it, and then I still have some leftovers from the first two. So then I give another dose, and I give another dose, and another dose. And eventually what you're going to find is that you reach a point to where your average level here is from these peaks to these troughs. This average level is actually equal to that continuous infusion. So even though there's variability, there's a vacillation between peaks and troughs, you still get the same average level. And that's a really important thing to get because, again, we're oftentimes not giving drugs continuously. So that means that we can have these big fluctuations that occur here depending on how we are giving the medication. So for instance, I can give a drug as a continuous infusion and get a very tight, steady level of that drug, which means I get very consistent effects, no variability for the most part. But again, that's not realistic. So what can I do instead? Well, I could give the drug, say, intermittently every 8 hours, maybe a small dose every 8 hours. And so what you can see here is I'm giving, with this kind of light gray line here, you can see that there is some variability between the peaks and troughs, but eventually I'm going to hit the same average steady state level here. And what you notice here is it's fairly tight between the peaks I'm getting and the troughs that I'm getting here, okay? Well, what would happen if I were to give the same drug at a bigger dose, but I'm giving it every 24 hours instead? What you can see is I'm giving a much larger dose here every 24 hours. The peaks are considerably higher. The troughs are considerably lower, but I'm still hitting the same average steady state level, right? So what does that mean for us? Well, that means that in some cases, this may be reasonable, right? And it's okay to give a drug every 24 hours if it's going to be effective and not cause toxicity, and it's good for the patient from a compliance standpoint. What are some problems, though, with this? Well, you can see issues where if these levels are this high, let's say, for instance, that toxicity occurs at 20 milligrams per liter. Well, I'm predisposing the patient to toxicity with levels this high. Or if I may have lack of efficacy if I drop down below 5 milligrams per liter. Well, now there's points here in time to where I'm actually getting subtherapeutic. I'm not causing enough therapeutic effect from the drug based on the concentration being too low. Right, so there has to be trade-offs here between the safety of a drug, the efficacy, and also the ability to give it in a way that the patient can take it and be compliant with that drug. A lot of patients can't keep up with every 8-hour drugs if they're doing it on their own, whereas if they're in the hospital, that may be okay. So it really depends on the context and the situation. Now, as I mentioned, it takes 4 to 5 half-lives to get a patient to steady state for a given drug, but what if I need it at steady state right now, right? Let's say that patient was in SVT, they have now deteriorated, and now they're in ventricular fibrillation, right? This is an arrhythmia that is not consistent with life, right? I need something like amiodarone to kick in a lot faster than 500 days, because my patient will probably have died 499 days ago, if that was the case. So what can I do instead? And this is where I can give something called a loading dose. A loading dose basically bypasses the time it takes to get to steady state. It's kind of like a shortcut. And so basically what I can do is I give a really big dose up front that gets me up to a steady state concentration, and then I follow that up with dosing that keeps me at steady state. Okay. If you've ever seen someone take a Z-Pak before, a Z-Pak is azithromycin. It's an antibiotic. If you notice, you can take 2 tabs on the first day, and then you take 1 tab on days 2 through 5. That first day is a loading dose. Or in these cases here, let's say I was going to give the drug lidocaine, which most of you probably know as a local anesthetic. It's also useful as a antiarrhythmic drug. And so what I can do here is give lidocaine as a bolus dose to get me at a high concentration steady state. So on this graph here, this black line is the steady state concentration. The red line here is that dose that gives a loading dose that gets me the steady state really quickly. As you notice that it's being metabolized, I follow that up with a continuous infusion, and that's that blue line right here. And so as this red line decreases, it is being helped out with this blue line, such that by the time that the red line is completely eliminated, that bolus dose, my continuous infusion has now taken over and is keeping me at the steady state level. Okay, so that's what loading dose. If you ever hear that, is like patient needs a loading dose of X, Y, or Z. That's what they're doing, is they're bypassing the time it takes to get to steady state to make sure the drug is effective right away. So to follow that up, though, that's where you get into the maintenance dosing. So you give a bolus dose and you follow it with maintenance dosing, whether that's a continuous infusion, whether it's a tab a day, whatever the case may be. And you're going to see here that a lot of that is determined based off of what concentration we want to get to, right? So if you recall that the steady state concentration is equal to that dose over the clearance in the dosing interval, well, if I want to rearrange that to figure out what dose I need to keep me at the steady state I want, I can just rearrange it to see here the dose equals the CSS times the clearance times the dosing interval, and I can actually figure it out quite easily. So anyway, so that's it for the pharmacokinetic section. Let me know if you have any questions on that currently. I'm going to not save that, and then let's see, let's go ahead and open up week 3. I'm hoping this is going to work out. I'm working on my streaming setup for you guys. Maybe I'll go pro and start playing some Minecraft for you at some point. Who could say? Check the sticky board real quick. No questions yet there. And see, no questions in the chat. So I assume that I'm teaching everything flawlessly and you just have 0 questions about my stuff. Because, I mean, come on, this is so simple, right? So Crystal says, could you explain the factors for Cockcroft-Gault equation? Yes. So the big ones I want you to think about are going to be the patient's age. I want you to think about the patient's their weight, and I want you to think about the patient's actual creatinine level. Okay. So as the patient's age increases, so think about elderly grandmas and grandpas. As their age goes up, you're going to find that their kidneys are going to start to fail over time, right? So it's just natural that our kidneys start to reduce in function. So as age increases, what you're going to find is that that 140 minus their age, that product there is going to diminish as age increases, such that an older patient is going to have a lower creatinine clearance than a younger patient, right? So just like you were looking at a 90-year-old patient versus a 20-year-old, I could pretty well assume, I'd probably have pretty good odds at saying that the 90-year-old has lower creatinine clearance than the 20-year-old, right? Assuming otherwise healthy, just because I know that kidneys fail over time. Everything fails in the body over time. So there's that. Weight, as weight goes up, generally you tend to assume that that is due to increase in muscle mass, such that like say for instance if you're looking at an 18-year-old patient versus someone who's 30, if their weight was different and their weight had increased, you could probably assume that some of that is related to muscle mass and things like that. So that does have a bit of a factor there. Note though that is within reason though, right? We can have extremely obese patients or extremely emaciated patients, and that there are some ways we can get around that, which is not really within our scope talking about it at this time. So don't get too hung up on that. But generally, as weight goes up, creatinine clearance also goes up as well. No, so in that case there, it's a proportional increase. As weight goes up, creatinine clearance also goes up in those cases. Because if you notice there, it was just weight by itself. It wasn't, something minus weight as it was with age, right? There's that. And then the creatinine is in the denominator. That's kind of the easiest one to sort of wrap your head around. So to note that if you're holding on to more creatinine, that means that I'm not clearing it from the kidneys, which means that kidney function is probably lower, right? So as creatinine clearance, as the creatinine level goes up, creatinine clearance goes down, right? It kind of makes sense that if I'm not clearing it, that means I'm holding on to it. And if I am clearing it, then I should be getting rid of it. That level should be low. So in those cases there, you're going to find that has probably one of the biggest effects in terms of estimating a patient's renal function, just looking at their serum creatinine. When I'm, say, looking at a patient, I'm kind of looking over their profile, I can just look at a patient's creatinine. If it's 3, I already know that patient's kidney function is not ideal. for the most part, right? Unless there's something else going on, some other process that increases creatinine. So in those cases there, I would still do the Cockcroft galt to determine what their actual creatinine clearance is in order to figure out how to dose my drugs. But I can already look at the creatinine and know something's off. I know something's kind of going wonky there, right? So those are the biggest factors. In other cases, you may find that if a patient's female, you factor that in, just based off the fact that females generally have less muscle mass as compared to male patients. Are there people that violate that assumption? 1000%, right? So it only works as well as the population you're dealing with, and it generally works pretty well for our patients, right? Will that change over time? And if I'm giving this lecture 10 years from now, I might say Cockcroft galt is garbage. We're using this new one. We're using the Wood equation that I came up with, that I'm now a millionaire based off of. That would be nice, but I don't know if that's actually going to happen. But regardless, let's get into the next section. Okay, so now we're talking about kind of another hodgepodge of topics here as we get ready to get into our actual medications here, and I'm already behind time as usual. So looking at adverse reactions, what does that really mean when I say adverse reactions? Well, basically it's any sort of like kind of appreciably harmful or unpleasant reaction the patient gets from using a medicinal product here, right? And in general, when an adverse reaction occurs, there's a couple of different things you may need to do in response to that, right? So maybe I need to initiate some treatment in order to prevent that adverse reaction from happening, because the patient still needs the drug potentially. Or maybe I can change the doses that they're getting, or I might even withdraw the product altogether. There's some reactions that are so severe that I'm just never giving that drug to that patient ever again, right? And there's kind of 6 different categories of adverse reactions that can happen here. And so they kind of follow this A, B, C, D, E, F mnemonic. If you look here, you can kind of follow by this. If that helps you, that's great. Otherwise, I will refer to them as their more descriptive categories. So like dose-related, non-dose-related. And I'll give you some examples of these as well. And so it's a good thing to be able to identify what type of adverse reaction it is in order to learn ways to mitigate it or prevent it potentially, right? First one is dose-related reactions, right? These are quite common, and it's generally related to the pharmacologic action of a drug, which means it's fairly predictable, right? So for instance, if I'm giving a patient a calcium channel blocker that's an antihypertensive, right? It lowers blood pressure. So presumably if I give too big of a dose, I'm going to get too big of a drop in blood pressure, and thus I cause hypotension. That makes sense. I can predict that because I can understand that, okay, I gave too big of a dose, patient's blood pressure is too low. Okay, maybe I'll give a lower dose next time, right? Generally has low mortality, and it can include a lot of general side effects you get from medication. So for instance, with diphenhydramine or Benadryl, I know that's going to cause sedation because that actually is related to the fact of its mechanism of action, right? So not only does it work for decreasing runny nose and watery eyes and itching related to allergic reactions, but it also causes some effects on the CNS function based on the fact that it's an anticholinergic and antihistaminic and all these different actions, which we'll get into later. But it's a part of the mechanism of action of the drug. I know that's part of the pharmacology of it. It's not surprising to me that someone would have that reaction, right? It says dose-related. So getting into the next one, how about non-dose related reactions? These are kind of bizarre reactions, things that we don't normally anticipate, or it's difficult to predict who's going to have that reaction. As a result of that unpredictability, it generally has a higher mortality, right? I can't look at a patient and know, are they going to have a reaction to penicillin if I give it to them, a true blue anaphylactic reaction, right? Or for instance, there's certain complications you can see with certain general anesthetics, certain inhaled anesthetics you might get for surgery, which can lead to malignant hyperthermia, which is this really horrible condition to where the patient's basically muscles all start contracting at the same time, and they start to break down, and they cause horrible hyperthermia and rhabdomyolysis and all these horrible things. It's a genetic predisposition that we don't routinely test for because it is quite rare. And so that's why you have to do proper screening for a lot of these things. That's why you ask about allergies for a patient, because you can't just look at them and tell, hey, do you have a history of penicillin allergies? You're just not able to. Now, other ones can be dose and time related. So not only do you have to consider the dose that the patient's getting, but also how long are they getting it for, right? So these are relatively uncommon, but they can overall be related to how long a patient's on a drug for, and then also how big of a dose they're getting. So a good example of this is adrenal suppression with corticosteroids. So when I say corticosteroids, I'm talking about things like prednisone and methylprednisolone and dexamethasone. You've probably heard of some of these before. You hear about like solumedrol or solucortef, hydrocortisone. These are all examples of corticosteroids, right? one of the things you'll find about this when we talk about them, because you use them for so many different disease states, is that if I give a large dose of that to a patient and they're on it for, say, like more than a week, the adrenal glands actually start to detect that, and they say, hey, well, we have enough steroids around here, I don't have to produce anymore, part of a negative feedback loop, and they'll actually shut down. And so then if I have a patient on that for a while, you can cause adrenal suppression to where if I then withdraw that drug from the patient, their adrenal glands can't keep up. They take a while to kind of wake back up, which is why frequently if they're on high dose steroids for a long time, you have to wean them off of it to allow the kidney or the adrenal glands to kind of catch back up. So again, not super common, but we'll talk about some very notable examples of these in the future. And this is related to both the time and the dose are on it, right? So if there's dose-related, time and dose-related, presumably there is time-related reactions as well, and certainly there is. These, again, are uncommon, and they are not related to the dose of the medication, and they're only going to be apparent when the patient has been on the drug for a long period of time, right? So some examples of this include things like teratogenesis, right? So say a patient with bipolar disorder is on the drug valproic acid, Depakote, Depakine, if you've ever heard of those. It's something to help manage their manic symptoms, right? Well, unfortunately, one thing you can find with patients with bipolar disorder is they may be predisposed to sort of high-risk sexual behaviors, including getting pregnant, for instance, or having unprotected sex to get pregnant, right? That's kind of the outcome of that. So if they're taking valproic acid while pregnant, that can actually lead to neural tube defects in the fetus, right? It can lead to fetal demise or significant birth defects when that baby is born. It's called teratogenesis, when you induce birth defects in a fetus as a result of drug exposure. And so this is something to where a patient may be pregnant for a while before they even know about it, right? It's not like, little cherubs come down from on high and shine a light on you, say, hey, you're pregnant. That'd be convenient, but unfortunately not reality. And so you get patients who are on this drug for a long period of time during this pregnancy before they realize the damage has already been done. Or it's a time-related reaction. Or if you have patients who are on antipsychotics, so some of the old school antipsychotics that we have, they have a condition called tardive dyskinesia that occurs over a long period of time, which basically causes them to have sort of involuntary muscle reaction. They have tics and they have tongue protrusions and all kinds of sort of odd physical mannerisms that develop as a result of being on these drugs for a long period of time. So time-related reactions there. And again, if I give you an example on an exam, if I ask you, hey, this reaction didn't happen until they were on it for the same dose for 10 years, you should be able to identify what kind of reaction these are, right? So if they're on the same dose for 10 years and then the thing popped up, that's probably a time-related sort of reaction, right? So those are kind of the things I want you to be able to key in on. We also have withdrawal or end of use sort of adverse reaction. So this is the opposite. So this is where adverse reaction occurs when a patient stops taking a drug, right? So as an example, if you've ever seen someone go through opioid withdrawals, it is quite uncomfortable for them because their body is so used to having that drug effect around, causing its normal physiologic effects, that becomes homeostasis for that patient. If you withdraw that all of a sudden, they can have things like severe diarrhea because the opioids were keeping the GI tract slowed down. Now all of a sudden it's waking back up. Or they get runny nose and they get really aggravated and anxious, all related to the withdrawal of the drug. Or in some cases, you can actually have patients who are on a drug for a long period of time. So like beta blockers, we talked about receptor upregulation and downregulation and how you can have sort of the opposite effect occur as a result of that regulation, right? So for instance, if I have someone who has a beta blocker like propranolol on board for a long period of time, you may find those beta receptors are upregulated, but they're still being blocked. And if you withdraw that drug all of a sudden, now all of a sudden you have that sympathetic nervous system has extra receptors to interact with, and that can actually induce myocardial ischemia, right? It can induce an MI in those patients there. So it's a withdrawal of the drug leading to the adverse reaction. Sometimes you can have failures of therapy, and so these are quite common. Oftentimes these are either related to the dose that we're giving, or it may be caused by drug interaction. So let's say you have a 70-year-old female patient and she's presenting with dysuria and you suspect she has a UTI, right? So you go ahead and you run your lab test and you come up with your diagnosis and you say, okay, I'm going to give you this fluoroquinolone. Fluoroquinolones are a type of antibiotic that we use frequently for things like UTIs, probably too commonly, but And so you say, okay, take these, go home, and then, call me up if nothing improves over the next couple of days. And so the patient is taking like they should be, but, they're elderly, worried about osteoporosis. What do they frequently take these things with? Well, maybe a glass of milk or maybe a calcium supplement. Well, calcium actually ends up binding those fluoroquinolones in the GI tract, rendering it inert and causing it just to be eliminated in the feces. So the patient's not getting any better after 3 days. They call you back up and you say, okay, well, have you been taking it like you're supposed to? And they say, yeah, I've definitely been taking it. But if you don't key in and say, okay, well, what are you taking with? A glass of water, a glass of milk? Unless you ask those sort of questions, you may not realize that it's actually a failure of therapy due to a drug interaction, not related to the patient being compliant, right? Sometimes the patient compliance, and frequently they're not going to tell you if they're not compliant, but you can at least rule some of these other things out, right? Or really another good example, going back to pregnancy being an unintended adverse reaction, right? Now, all pregnancies are little blessings, I suppose, but you may find that an unplanned one may be quite distressful to the patient, and you can actually have this as an interaction, right? So if a patient is on an oral contraceptive, an estrogen-based contraceptive, and let's say, for instance, that they're also on another drug that upregulates the enzymes responsible for metabolizing that estrogen. Upregulating the enzymes, so that means they're metabolizing the estrogen more quickly, which means estrogen levels drop, which means the patient may ovulate and become pregnant, right? We'll get into the details of that later on when we talk about OB-GYN stuff and more specifics, but that interaction may lead to failure of the contraceptive, patient becomes pregnant, and that's the adverse reaction essentially, right? Because that's not something that they were really planning on. So when you're looking at the term adverse reaction versus side effect, we may use the two interchangeably. Generally, side effect is referring to something a little less severe, a little maybe bothersome to the patient, but maybe something that you can sort of take the good with the bad, sort of, and even though it's not desirable, it's okay. Or you can do some things to maybe try to prevent it or ameliorate it. Versus adverse effects generally being a little bit more severe and usually prompting changes in therapy or initiating additional treatments in order to manage them. I'll give you some examples here in a moment. But side effects can be a good thing too, right? So the drug bimatoprost, which some of you may know as the brand name Latisse, actually is originally used for glaucoma. We get into ophthalmology, we'll talk about why that is. But one of the side effects of it was that it actually increased eyelash length. And so they realized, like, we can maybe have a bit of a market for this. And so now you see Latisse being used very frequently as an aesthetic sort of product to increase volume and length of eyelashes there to make women or whoever look more pretty, I suppose. I don't know necessarily I've ever noticed someone's eyelashes before, but I'm sure some people have and have thought, wow, that's a nice set of eyelashes. And it could be brought to you by Latisse, right? Unfortunately, I'm not sponsored by them, so maybe it's a free plug. But anyway, but also there may be some other side effects that can occur along with that that you should worry about. So, for instance, if someone has pretty blue eyes, they may want to keep them blue, and the drug itself may actually turn the iris brown. So that if they don't have brown eyes to begin with, that may be unfavorable to the patient. So again, you have to kind of monitor for that sort of thing and let them know that, hey, here's some good sides, but also here's the bad sides that could occur here. Crystal asked, would Latisse have something like tolerance occur? I'm not sure that Latisse develops any tolerance that I'm aware of. I think as long as you're using the drug, that it is working. If you stop using it, then it would go back down to baseline. It's not going to cause any sort of permanent change there. So like if they stop Latisse after using it for a long time, so it would be tolerance, but you do go back to baseline. Just like if someone's on an antihypertensive drug, it lowers their blood pressure, and some of them think, okay, well, my hypertension is cured, I'm good to go. And they stop taking the drug and their blood pressure comes back up, right? So some of these things you have to take consistently, otherwise the effects do not stick around. It'd be nice if there's some switch that I could flip to cause your eyelashes to increase in length, but that's not necessarily the case, unfortunately. So just to give you an example here, looking at the drug Bactrim, which is a combination antibiotic of sulfamethoxazole and trimethoprim. So here, an adverse reaction being more severe could be something like Stevens-Johnson syndrome, which is a very severe skin reaction you can see here, where basically the patient's skin will start to slough off. They'll develop blisters and all kinds of horrible things, and it's quite fatal if not caught early and managed supportively in a hospital setting. That's pretty severe. You want to let your patients know that this is a possibility. However, it's fairly rare. Or if you know that a patient has a history of Stevens-Johnson, you would not want to then re-challenge them with this drug, right? Versus a side effect being maybe rash and urticaria in sun-exposed areas. So we call that photosensitivity. that may be okay because you can tell the patient maybe not go out in the sun, or maybe put on high SPF sunblock or something like that in order to prevent that from occurring. So kind of generally you can see the differences here. Another one, the drug Viagra, which is used frequently for erectile dysfunction. Sildenafil is the generic here. Side effect of it is related to its mechanism of action. It causes upset stomach, right? Just like it relaxes blood vessels to cause an erection to occur, it relaxes smooth muscle in the lower esophageal sphincter and causes GERD to happen, right? So that's a normal thing. I'd let patients know, hey, this is a possibility. But maybe, avoid large meals, maybe avoid spicy foods, etc., to get around that, because it may be worth dealing with this in order to get the therapeutic effect out of it, right? Versus an adverse reaction would be something like sudden loss of vision. There's not a really good case to say, okay, well, you can have sex now, but you're going to be blind. Most people are probably not going to think that's a good cost-benefit sort of analysis there, and they'll probably say, I'm okay, I don't need that drug. It's rare, but you at least want to warn patients about it being a risk. So you say, hey, if you ever have any changes of vision, stop taking the drug, call us up, go to the ER, etc., in order to deal with that, right? Another good example is lisinopril, which is an ACE inhibitor. This is an antihypertensive drug. A lot of patients will develop a non-productive cough along with this. And again, it's related to the mechanism of action of the drug. And for some patients, this is fine. They don't really notice it. It's okay. For other patients, the cough is so constant and nagging that, it causes their significant other to practically want to kick them out of bed. That's not going to be a good drug for them, right? But it's something that, again, you have to do kind of a pros and cons sort of analysis there to determine, do you want to continue with that drug or maybe switch to something else? Versus they develop angioedema. Here's a picture of a patient with angioedema. And you can just look at there and you're going to say, wow, that tongue is quite large. I wonder if it's going to be blocking off the airway anytime soon. And chances are it will be. And their whole, upper respiratory tract can become swollen and can occlude the airway, leading to respiratory failure and death, right? Very severe reaction, something we'd have to do something about promptly, right? Either go with maybe a nasal, get a nasal tracheal tube established using fiber optic cables, or do a tracheostomy or something like that. But something needs to be done here immediately because of that angioedema. So again, you kind of get an idea between side effects, which are relatively minimal, we can do something about, versus adverse reactions are going to prompt new therapies or will prompt immediate discontinuation of the drug. Okay. The next thing I want to talk about real briefly is going to be therapeutic drug monitoring. This is where basically we can use levels of a drug in the plasma in order to determine, is the patient's level too high, too low? Are they high enough to get the therapeutic effect we're looking for, but not so high that they're going to be predisposed to toxicity? And so when looking at this, two things I'll mention here, and I've mentioned it before, include peaks and troughs. Peak being the highest level that you achieve after giving a dose of a drug, and a trough being the lowest level prior to the next dose being given. Okay, and again, most drugs are given intermittently, so you're going to get this vacillation here between peaks and troughs, but you'll have the same sort of average steady state level sort of achieved here, right? So this is really important to help us to determine, are levels high enough to actually treat the patient, but not so high they're going to cause issues of toxicity. And you can see here, based off of this, whether I'm giving a drug at smaller doses more frequently, that can have a big effect on the levels, as opposed to higher doses given less frequently, right? For some drugs, this may be okay to get these really high peaks because maybe that actually increases the efficacy of the drug. For other drugs, though, this can lead to some big problems here. So some drugs you can get away with doing this sort of dosing strategy, no problem. Other drugs, you have to rely on something more more tightly regulated between the peaks and the troughs to prevent issues. We'll talk about some of those examples later on. But TDM, or therapeutic drug monitoring, is using those levels of the drug, responding to that by analyzing the pharmacokinetics of the patients, and then individualizing it in order to get the most optimal drug therapy for that patient, right? So instead of looking at a book and saying, okay, this drug is dosed 500 milligrams every 6 hours, I can start with that dose, see how the patient responds to it, look at the levels, and then adjust it to make it just right for them. So instead of 500 milligrams every 6 hours, maybe I'm giving 400 milligrams every 8 hours. Maybe that's what's right for that patient. And so it's a way of using drug levels to help us respond to how the patient themselves are working, right? Because when you are looking at a drug reference, you look at a book and it tells you a dose, that's assuming that you're dealing with a normal patient and they all act the same. We know that's not the case. We know patients are individuals and they may react a little bit differently. And what do we do this for? We don't do it for every single drug. We actually do it for a relatively small number, although we do it for some that are pretty high volume. If you work in a hospital setting and you're looking at certain antibiotics, we're going to see this is a frequent one we work with. But we do it for drugs that have a narrow therapeutic index most often, right? When there's a high degree of overlap between the efficacy of the drug and the toxicity. Or if we're looking at drugs that have a wide therapeutic index, we don't really care because the difference in dose between getting the therapeutic effect to causing a toxic effect is so wide that there's no need to, right? Because the patient, I can just look to see how they're responding to it. They don't develop toxicity, no issues. But some of these things may be more hard or more difficult to detect. So if the adverse effect is something like renal damage and it takes a week for it to manifest, that may be, I may be behind the 8 ball by the time I determine that patient now has renal dysfunction. As opposed to if I were to use the drug levels instead to predict that, then I can go ahead and be prospective and be more proactive in order to change that dose and prevent that adverse reaction from occurring in the first place, right? So as I mentioned, it applies to a relatively small number of drugs. And frequently you want to make sure that the efficacy of the drug can't be determined more easily by looking at other measures, like direct measures. So as an example here, if I'm giving an antihypertensive and I want to see if it's working, well, I just measure the blood pressure. That's pretty easy as opposed to getting a level of the drug itself, right? Or if I'm giving them a drug to treat their high serum lipids, hyperlipidemia, I can just go ahead and measure their serum lipids. That's easier than looking at a drug level, right? So there's a direct measure to see how drugs are working. Sometimes you have drugs that work via other measures that I can also measure. I can look at to determine how well the drug is working. So the anticoagulant warfarin, which is a blood thinner, I can just go ahead and look at a patient's PTINR to determine how likely or unlikely they are to develop a clot based off of how long it takes for their blood to coagulate it, basically. So again, TDM does not necessarily apply to these type of drugs because I don't really care what the serum level of the drug is. I can look at these other measures to determine how efficacious or potentially how high of a risk of toxicity that patient is at, just using those measures, okay? So that's one of the downsides of TDM is it doesn't really apply to a huge number of drugs, but where it does apply, it is quite important, and we'll see that we use some of these drugs quite frequently. So anyway, so drug response is related to the exposure that the patient has to the drug itself, right? So there are some things here that affect this. So for instance, there's bioavailability of the drug, so how much actually gets into the system. There's the clearance of the drug, so how well they can get rid of that, which is, as we recall, related to the half-life and things like that. These are things a clinician doesn't directly control though, right? So I can't control how well a patient absorbs the drug from the GI tract, nor can I change a patient's renal function, save putting them on dialysis, for instance. I can change it then, but for the most part, you really can't modify this. However, what I can control though is going to be the dose I'm giving and how frequently I'm giving it, right? So this is frequently the things we're going to change when we're undergoing therapeutic drug monitoring for a patient. Based off these changes here in bioavailability and clearance, right? So let's say, for instance, I'm dosing a patient on a given dose of drug, say 500 milligrams every 6 hours, and everything is looking good. The exposure is perfect. They have just the right levels, but now all of a sudden the clearance goes down, right? Well, because the clearance has now gone down, say the renal function dropped by half, this means the exposure has now gone up, which may predispose them to developing toxicity. Well, what can I do about that? Well, I can modify either the dose I'm giving the drug or the interval in order to account for that, either give a lower dose or a longer interval in order to get the exposure back down to normal, back to what was therapeutic previously. And that's what therapeutic drug monitoring is, right? We measure the exposure by measuring blood levels. We determine what changes have occurred here in either bioavailability and clearance, and then we respond to that by changing the dose or the interval, okay? And so this is not absolute when you look at a therapeutic range, but it's based on probabilities, right? It's based on the probability that if a patient is within these ranges, say 10 to 20 mics per ml, for instance, for a drug, that they are at a high probability of achieving efficacy and a relatively low probability of developing toxicity, okay? Does that mean that patients always have to be within those numbers to be efficacious? No, some patients can have a low level and still achieve efficacy. Some patients can be at a high level and still develop no toxicity, right? So it's important not to just look at a drug level and say, wow, that's high or low, and then respond to it. You got to look at the other stuff too. How's the patient responding to it? If you're giving them an antibiotic, is their white count coming down? Is their fever coming down? Are these sort of things here. And it kind of goes back to the mantra, which you'll likely hear from many of your teachers, is that you treat the patient not the number. Never ever get a lab value and respond directly to that. Take into account the whole patient and what their clinical picture is to make a decision on how to modify these things here. Sometimes the best thing to do is nothing at all, right? So how do we do this, right? So one, you want to make sure that patients are at steady state when you are looking at therapeutic drug monitoring, right? You don't want to measure levels too early. Now, why is that? Well, because if you measure before steady state, where they hit that kind of plateau where that average steady state is achieved, you may think the levels are too low. And if they're too low, you may think, okay, well, I need to give more drug. And so you change the drug dose, you give more of it, and all of a sudden they have a new steady state. It's even higher, and that may now be too high. So make sure you're at steady state when you do this. And this is one of the big mistakes I see many clinicians do. It does not matter if they have been attending for 40 years or if they are a new fledgling PA right out of school. Everyone messes this up, which is why it's nice that we have a team. And you have people like me that can call you up and say, hey, are you sure you want to order that level that soon? Sure you don't want it later? That's what we do, right? Work as a team together. So anyway, so let's say we get that level back, we're at steady state, and we look at the two scenarios. Either one, they're having an adequate response and they have a good level, we continue treatment, no need to do anything. Or we have the scenario B, which is where we have levels that are too low or they are too high, right? So subtherapeutic means they're too low, or toxic or supratherapeutic, too high. And then at that point, we manipulate either the dose or the interval in order to get them back under control, to get them back into the right range, okay? And so why do we do this, right? So one, we're going to be using this to provide additional information in conjunction with the other stuff too, right? So again, how is the patient responding? What are their other lab values doing in order to determine, do we need to change this dose? Do we need to change this interval to make sure we can modify these levels here? And it allows us to individualize the dosing regimen, right? Not every patient is cookie cutter and is going to act the same exact way. And it also takes into account things like, well, what physiologic status changes have occurred? Is their renal function changed? Their cardiac function? How is that affecting things? Their liver function? And then we can also look for things like what kind of drug, food, or herbal interactions may also be playing a role here as well. Or let's say you have a patient who is non-adherent, right? So if I check a level for a drug and it's 0, it probably means the patient isn't taking it, right? And so I can kind of identify these sort of things by using those drug concentrations. So other information you want to have available when you are doing therapeutic drug monitoring, you have to know when the blood sample was taken and the time that the last dose was given. This is where it's really important for good documentation to occur. I run into this all the time at the hospital where a nurse will go ahead and report, they'll draw the blood, they'll send it to the lab, and the level comes back extremely high. And I'm like, whoa, this level is way too high. Let's say I was looking for a trough level. Remember, a trough is right before the next dose. And level comes back extremely high. I'm like, whoa, this is something going on here. But the patient's kidneys look good, everything else looks fine. Something's weird here. And anytime a level just doesn't look right, you assume that something's weird's going on, and you have to investigate, right? So be a detective, put on your little Sherlock Holmes hat, and check it out. And frequently what happens is the nurse will have given the dose of the drug, and they say, oh, I have to give it a level here. They're not realizing that it's a trough level, and then they'll get the level right after the dose is given. So now it's a peak level and not a trough. Now we got to start all back over again because I didn't really care about a peak, right? So it depends on the situation. So you want to also know how the patient's actually being dosed, so how frequently, what dose they're getting. You want to know the patient demographics, such as their age and their renal function and all these different things here. The reason why you're monitoring, is it because you suspect they're toxic, maybe they're developing a side effect, or are you thinking they're subtherapeutic because maybe their white count's not responding or their fever's still high? What's going on? And then you have to know what the desired range is, right? You have to know what range you're actually looking for in order to get that level and interpret it in the first place. And not every drug is going to have an established range. Now, what kind of drugs do we frequently do this on? Well, oftentimes it's going to be drugs with a narrow therapeutic index, meaning that small changes in dose may lead to a unacceptably high risk for toxicity. So things like anti-infectives, so vancomycin and the aminoglycosides. Don't worry about memorizing this list. We're going to talk more about these when we get into their individual sections, so just hold on to that. But things like vancomycin and aminoglycosides, a lot of cardiovascular drugs like digoxin, a lot of anti-epileptic drugs, so things like phenytoin, carbamazepine, valproic acid, and then sometimes we'll even do this for things like immunosuppressives for patients who have had, say, transplants, or if they have rheumatologic conditions, things like that, to suppress the immune system, because we want to make sure we don't suppress the immune system so much that they're at risk for developing all these infections, right? So oftentimes you're towing a fine line between preventing the risk for issues from their disease state flaring up, like say with an anti-epileptic, I have to measure the risk of them having a seizure versus them having adverse effects from the actual drugs themselves, right? So it's a tight line to walk. That's why we do these therapeutic monitoring, why we measure these levels in the first place. There's some limitations though, right? So anytime you're doing additional lab tests, there could be issues in terms of cost. If a drug has a really wide therapeutic range, then it may not be all that important because it doesn't really matter where they're at as long as they're, having good effects from the drug and all that. So that's one reason why you wouldn't want to do it. Maybe there's not a good correlation between response and concentration. If that's not been established, you just get a level just to get it, then it doesn't tell you anything. It doesn't tell me, is this a level too high or too low, right? Because there's no relationship to that response there. In some cases, reference data may not be available, or I may actually have direct response measures I can use instead. So I can measure that patient's blood pressure. I can, measure the INR for someone who's on warfarin, right? There's a lot of things you can do as direct response measures that don't require blood levels of that drug, right? Some benefits, though, are improved efficacy of the drug. You have less risk for toxicity when you do it, and sometimes it can actually be cost effective because you can actually decrease length of stay. So if I can get a patient who needs vancomycin for an infection up to the right level right away, as opposed to it taking weeks and weeks, you may be able to clear that infection faster and get them out of the hospital more quickly. So those are some of the proposed benefits you can see there. So how do you do TDM? Well, basically, you want to start off with the reason why you're monitoring, right? So, are you doing it as a routine sort of thing, or is there a specific indication? Like you're thinking maybe they have a lack of response, or maybe, say for instance, someone with a seizure disorder, you're dosing their drug and they have a seizure, they have a breakthrough seizure. You want to find out, well, is it because their level of drug was too low, or is it because of something else going on? It could be a reason, right? Then you want to make sure the blood sample is done correctly, so it's done at the right time in relation to the dose that they got. And also, things like the right collection tube is really important too. And so you may learn about this if you have a class more focused on labs and things like that. But there's many different types of tubes that you could use to collect blood. And so, for instance, one of them is a lithiated tube. I mean, it has lithium in the tube itself. If I'm measuring a lithium level in a lithiated tube, guess what? It's going to come back high. And so I'm going to think that I need to change the dose of that drug for the patient, and that may not be the case, right? Next, you're going to get your laboratory measurements, and then you also want to consider the communication back of those results. So depending on where you work, they may measure things at different levels. They may use different units there. And so I had one time I had a patient who had an aspirin overdose. So I was at the poison center. I was consulting on the case as a toxicologist, and a normal level for aspirin is like 15 to 30 milligrams per deciliter. Patients are high risk for death once they get up to like 100 milligrams per deciliter, right? So anyways, I'm on the phone talking with this provider, and I go, well, what was the repeat aspirin level? And they go, oh, it was 400. And I said, okay, well, did you call the chaplain? And they're like, what are you talking about? The patient's fine. I said, well, level 400 is not really compatible with life. Like, what? Something's going on here. I said, what are the units you're using? And he goes, oh, it's micrograms per ml. I had to do the conversion in my head. And I said, when you convert mics per ml over to milligrams per deciliter, the patient's level is 40, which is elevated, but not necessarily to the point that I was really worried about when I heard that number of 400. So, those things you have to really consider. So if something doesn't sound right frequently, it's not right, as the case may be. So then, you can then optimize your drug treatment. So at that point, you either modify the dose that they are getting, you modify the interval that they are receiving it at, or you may actually change both. And at that point, you can rinse and repeat. You allow the new dose to get to steady state, and then re-measure that and see where you go from there. Okay. So that is that for the TDM section. I could go and do a whole course about that, but again, that's more suitable for pharmacy school and not for our purposes. But next off, I want to talk about rational drug prescribing. You're like, what the heck does that even mean? Well, rational prescribing basically is this therapeutic approach to determining, like, what do you do for a patient in terms of prescribing specifically, because frequently a diagnosis is going to often come up with some sort of prescribed treatment, right? Whether it be surgery or radiation or whatever, but a lot of times it's medication, right? And again, I'm not one to push meds because it's job security for me. It's just the matter of fact that most patients do require medications for many different conditions, and frequently it does require prescriptions, which is what I'm going to be focusing on here. And most of the time patients want a prescription when they come into you. If you are coming in with the cold and they want antibiotics and you tell them, well, it's probably a virus, they might get mad with you, right? They say, well, I want you to do something. I don't want to come in to see you. You tell me there's nothing I can do, get some rest. They'll feel like they kind of got gypped, right? Why did we even come into the provider in the first place? So what do we want to do? We want to make sure that we're following a stepwise approach to rationally prescribing drugs to these patients here. So first off, you have to make your specific diagnosis, which is where your forte comes into play. I did not get trained on diagnosis when I went to pharmacy school. Most of the time, my patients already have one by the time they come see the pharmacist, right? And so this is where they want you to do something once you make that diagnosis. And as I mentioned, unnecessarily writing prescriptions for a given diagnosis can, while it may satisfy patients, may lead to unnecessary cost. It can lead to unnecessary drug interactions. It can lead to antimicrobial resistance. So you got to know specifically what your tentative diagnosis is to know what's appropriate, what's not appropriate in terms of meds the patient may require. So let's say for instance, we have a patient with rheumatoid arthritis, right? We presume they have this based off of like lab values and based off of their physical exam findings and history and all this kind of stuff, right? Once you figure that out, then you have to be able to, describe that to the patient. Why do you think they have RA in the first place, right? And then you want to consider what the sort of pathophysiologic implications of that diagnosis are, right? So you don't know about this right now, but eventually we'll get into it. But you have to know about the disorder and sort of the pathophysiology and how it causes the effects that it causes, right? So for instance, knowing about the inflammatory cascade and knowing about, why we use non-steroidal anti-inflammatory drugs for that. And make sure when you're explaining to the patient in terms of the pathophysiology to talk to their level, right? Make sure you're not talking at the PA level to someone who has almost no medical knowledge whatsoever. They're going to just gloss over and not understand anything you're talking about. And there's lots of resources online that helps out with patient education that gets it down to, different graded reading levels and things like that can help out. Next, so you want to select your therapeutic objective, right? So based on the pathophysiology, you have to come up with your goals here. So for one, with someone with RA, well, I probably want to help out with the joint pain that they're feeling there. So that's going to be one thing, is to reduce the inflammation to relieve pain for that patient. And the next thing would be to arrest the course of disease progression, right? So I want to make sure that the joints stay good for as long as possible, or I slow down the joint disease progression. And so those are different goals. And sometimes the goals can be treated with the same medication. Different goals can be. Oftentimes they're going to require whole new drugs, right? So you may require 2 or more drugs in order to achieve these different goals here for the patient. Next off, you want to select your drug of choice. And so based off of that, you may have 1 or more drug groups that can satisfy the need for that goal. But you may find one may be better from like a efficacy standpoint, one may be better from a side effect standpoint, etc. And also take into account things like, well, what other meds are the patient taking? What disease states do they have? How old are they, etc. And so an example here with RA, does the patient have a history of like aspirin intolerance, or have they taken NSAIDs before and had peptic ulcers as a result of that? Is cost going to be a major issue? Which, guess what, for most patients it is. So do they have insurance that can cover some of these things? From a compliance standpoint, is once daily dosing going to be important for them, or can they get away with more complicated regimens? These are all questions you want to ask your patients. Next, you want to determine the appropriateness of the drug regimen. So this is going to be determined by kinetics of the drugs themselves, right? So looking at things like, okay, well, I know my patient has kidney dysfunction, so I may need to drop this dose by half. Or I may need to give it, instead of every 6 hours, I need to give every 12 hours, right? And then again, what's the patient going to be able to tolerate? If they're taking medication every 6 hours and they're taking 3 different meds, that can be pretty difficult for many of them. So you got to figure out what they're able to keep up with. And then you have to come up with a monitoring plan, right? You can't just write the script, send them on their merry way, and assume everything is going to work out fine. You have to come up with a monitoring plan to see, like, well, what are they looking for in terms of if the drug's working, or if it's not working, or if they're having some severe issues to where you may need to change the drug out altogether, right? So for instance, here when you're looking at antibiotics, like, you have to explain why you need the patient to take the full course and not just take 3 days to start to feel better and then they can stop, right? You need to talk about lab monitoring they're going to require in order to make sure the drug's working or not. You need to talk about what would constitute changes in therapy, or calls back to, or trips to the ER. So for instance, if I had a patient who was taking an NSAID for their RA and they had a black tarry stools, that would be a pretty big deal because that could be indicative of GI bleeding. I would probably tell them call the office, stop taking the drug, go into the ER, any of those things in order to help manage that, right? And then talk about education, right? So you have to come up with a plan of education for the patient there to make sure to consider things like language barriers, age barriers, educational barriers, all these sorts of things, right? Just because you're talking to an adult does not mean that they are at the same level as you. So you have to bring it down to their level. We are in, I'm not currently in Orlando, but I work in Orlando frequently, and you find that that's a large travel hub, right? And so you're going to have people coming in from all different countries that may be speaking many different languages. So you have to be able to account for that, right? So I'll never forget, I had a patient who was in from Brazil, and one of the techs from the ER came out, and they talked to one of the Spanish-speaking doctors, and said, "Oh yeah, they're from Brazil. You can go talk to them." And she's like, "I do not speak Portuguese." That's important, right? Because you may not realize that there's a lot of different language barriers. Just because you have a Spanish-speaking doc doesn't mean they can speak to anyone from South America, right? So there's a lot of sometimes unfortunate assumptions that people can make based off of that. But we have tools and we have things that can help us out in order to overcome those sorts of things. So we have like a little iPad that rolls around that actually can provide language services and call lines and things like that. But here's an example of one really good one where you'd want to provide good patient education for. So let's say you have a patient, say a 6-year-old, and they develop new onset seizures, right? And so seizures can happen at any point, and so you want to have patients carry around with them a medication that can treat those seizures emergently. And so here's an example of one called diazepam, which is the generic. Diastat would be the brand name for this one, and this is a rectally administered gel, right? So you have a 6-year-old, they have a seizure. They're not going to be able to administer this themselves because they're seizing, right? So the parents are going to be the ones to give this. And so it can be quite harrowing to see your child seizing in front of you and to have to remember how to use this device you have to insert rectally in order to administer the drug can be pretty scary, I imagine, for most people, especially if they're not really medically literate. And so you have to educate them and let them know how to do this. So provide them with pamphlets online, provide them with trainers that can help out with this. So that way they get used to the process. That way when the event occurs, they can respond a little bit more competently and not be so freaked out, right? Education is super important, okay? So that goes into actually writing a script itself. Like, how do we write our scripts? Well, this is going to come into play with the prescription writing assignment that we're going to be having coming up. I don't remember if it's this week or next week. I have to double check. But basically, this prescription assignment, or when I talk about prescriptions, it's any written, verbal, electronic order that is being sent to be fulfilled by someone else, whether it be the pharmacist, the lab, whoever it might be. And prescribing practitioners can range pretty greatly, depending whether it's your physicians, whether it's your advanced practice providers like PAs and nurse practitioners, podiatrists. Any of these people here can be writing scripts that may be filled, for instance, at the pharmacy. In general, you're going to find that you may be at odds with either looking at state laws versus federal laws. In general, you want to go with whichever set of laws is more strict. And again, sometimes there's going to be a mix of the two there, as you're going to see there. That way, if you go with whatever is more strict, you're going to be satisfying both state and federal laws there. Or if it's not addressed in the state laws, then you follow the federal laws. You'll get kind of used to this when you're on rotations and whatnot. But in terms of prescribing errors here, all prescriptions should be legible and unambiguous, and they need to have enough information provided such that the other healthcare providers who are taking that script can interpret it and can act on it appropriately without having to assume too many things. Because we all know what happens when you make assumptions, and they're not good. So this is why we're trying to prevent errors here. So let's look at the Florida statutes real quick. Basically, these are the requirements needed for non-controlled substances, right? So these are going to be non-narcotic substances, and I'll talk about the difference here in just a little bit. But basically, if these are written or typed, they have to be legible. If they're writing them out, no chicken scratch handwriting here. You have to include the name of the practitioner, the name and the strength of the drug prescribed, the quantity of the drug to dispense, the directions for use. They have to be dated, right? So you have to actually see when the actual script was written. And then it have to be signed by the prescriber on the date issued. Sometimes it's, you may think I can save time by pre-signing a bunch of scripts. You don't want to do that, because if someone were to acquire those, they can then potentially, write for whatever they want if your signature is already on there. And then they can either be called in or they can be communicated electronically. They can be faxed into the pharmacy, whatever. Generally, if it's called in, we will then reduce it down to writing in the pharmacy itself, so we have some record of that. And in general, this is a good point here to know that all prescriptions are only good for 1 year at most. So you can write a script for a patient and say they're going to fill it every single month, and you can write for 36 refills. We're not going to honor that. We're only going to give them as much as 1 year, and then it expires, and they have to come back and get another script from you, right? So note that you can have multiple non-controlled orders go on the same prescription. So I could write for multiple blood pressure medications on the same script, and that's totally reasonable. But any controlled substances have to be separated. And then we'll talk about C2s in a moment here, but they have to be on their own script all by themselves here. So here's an example of what this would look like. And when you see the prescription assignment, we're going to see that you're going to be filling in most of these things here as well. Do note that when you do the prescription assignment, I don't care if they're electronically written, meaning using your handwriting on a stylus, on an iPad or a tablet, whatever, that's totally fine. But everything has to be handwritten, right? So whether it's in pen, pencil, hopefully not crayon, written digitally, handwrite everything. So don't pre-fill in anything, because I'm trying to get you into the process of seeing what is absolutely needed. I'll get to that question in just a second, Paige. This is a good one. I want you to get into the process of writing everything that's needed, so that way you kind of know what should be there, what doesn't have to be there, etc., in order to write a good legal script here. Paige is asking, do the scripts need ICD-10 for the patient's diagnosis as well? For pharmacy's sake, they do not, right? So certainly for your medical documentation for billing and things like that, yes, you do need ICD-10. When you actually write the scripts out, you don't have to include that. It's unnecessary information from our standpoint. We would write, say for instance, we were trying to fill that script through someone's insurance. If they rejected it, sometimes they'll need what they call a prior authorization, which means we have to call the insurance company, or they have to call you in order to get the ICD-10 codes in order to make sure they have the right diagnosis for a particular drug. That's usually for more expensive drugs, or something that may be, not first-line therapy in a lot of cases there. Now, what are some issues here where we see a lot of prescribing errors actually happen? Well, frequently, you're going to see that is due to omission of information, or assuming people have information that you have that they may not actually have. So, for instance, saying blanket statements like resume pre-op meds or continue present IV fluids, you want to be more specific about that and say continue D5 half an S IV at 125 mLs an hour. You got to be very specific about this stuff, because otherwise people have to make assumptions, and that's where medical errors can really pop in. And so you may find that people may fail to discontinue prior medications. We start a new one, which means you have duplication of therapy. You may find that you may have issues where someone gets an immediate acting drug when you intended them to get a long acting form. All these sorts of things here. And a lot of times patients or providers will write scripts that say just PRN. So take this PRN, which PRN means as needed. You really need to be specific about that. So as needed for what, right? This is a big issue with the Joint Commission. We're going to talk about it at a later time, but they're really important for a lot of hospitals to get accredited. You have to write for what, and I'm going to really require that on my scripts as well. So if something is for pain, then take it as needed for pain. If it's for control of their blood pressure, say for blood pressure control or for glucose control or whatever the case may be, so that someone else can read that script and know specifically what it's being used for. Because many drugs may actually have multiple uses, and it's important to be able to double check the dosing that you're using based off the indication. If you're right what the indication is, then I can do that, right? Other providers can do that. Frequently, though, you're going to see errors pop up with illegible handwriting. So this is largely being supplanted by e-prescribing, which is very helpful, but you may still see scripts that come in like this that are unintelligible. I went to school to learn how to read a lot of this stuff. I had 4 semesters just how to read doctors' handwriting. I'm kidding, we did not do that, but my handwriting is almost this bad, and this is not acceptable, right? So make sure things are neat and clean. These are some other common errors that I run into that I want you to be aware of, and I will dock points off of if you make these errors. So making sure that you're not having unnecessary decimals here, or you're including decimals, not including decimals that are needed. So for instance here, so if I have something like 0.1, if you just wrote 0.1 milligrams of something, it's easy for someone to read that and they miss the decimal point and they just read it as 1 when it's handwritten. That could lead to a tenfold overdose, right? So you want to make sure these are always preceded. Anything less than 1, proceed with a 0. Say 0.1, 0.2, whatever, okay? That way it's very obvious that that's what you meant. Also, do not include unnecessary zeros after a decimal. So instead of writing 1.0, someone could read that as 10. So if it's a whole number, just write the whole number. Don't write 0.0 0.00. Some of you might be used to that from, say, undergrad or other programs where you're in a more science sort of mode where you're trying to denote how specific something is being measured. I don't care about that. I care about legibility, making sure that the patient gets the right dose that you intended for them to get. So don't write unnecessary zeros here after the decimal point, okay? Also, do not use U to denote units, right? Because that can be misread as a 0 and could lead to someone getting, instead of 10 units of insulin, 100 units, and that could be fatal, right? So you gotta be really careful, especially with these high-risk drugs like insulin. So always write out the word units. If something is dosed in international units, you can still just write units. That's totally fine. I'm not gonna dock you if you write out international units, but just write units. It's just easier that way. Instead of writing UG like this, just write out micrograms. MCG is totally fine. It's less likely to be confused than something like UG for MG, which is a 1,000-fold overdose. You would not want to do that. We also do not use the term QD. QD means daily, but has been misinterpreted by others in the past as like QID, which instead of 1 time a day, they're beginning of 4 times a day. So that's a big oopsie. Always write out daily. So you can write out, take it Q day, Q daily. Any of those are fine. And then not writing out full drug names. This is less common nowadays, but a common one that happened in the past was mixing up MSO4 with MgSO4. MSO4 is morphine sulfate versus magnesium sulfate, MgSO4. So, as you might imagine, someone who is requiring morphine, if you give them a dose of magnesium, they're probably not going to be too thankful for that because they're still going to be in quite a bit of pain, right? So some other things too, you want to make sure that you include strength and dosage forms. So because meds might have multiple strengths, multiple dosage forms, you have to be specific about that, right? So when writing out something like, metformin, which is used for diabetes, write out metformin 500 milligram tablets, which is different than the 1,000 milligram tablets, right? Because your instructions may just say 1 tab you daily. That's not appropriate, right? Because we have to know what the strength the actual tablets are themselves to make sense of that. And then don't write things in teaspoons or tablespoons. That is old nomenclature. Just use mLs. For those of you who don't know, a teaspoon is 5 mLs and a tablespoon is 15 mLs, right? But depending on where you get your spoons from, if you get them from Walmart versus IKEA, you may find the spoons do not measure exactly. So most places will now dispense dosing syringes for your patients. It is much easier for them to now measure things in specific mLs, okay? Then make sure you include the quantity of the drug and make sure it makes sense based off what's prescribed. So if you say take 1 tab daily and it's something they're going to be taking, with no definite durations, they're going to take it forever, presumably, then it should be a quantity of 30. If it's take 2 tabs twice daily, it should be 4 times 30 because it's 4 tabs a day. So 120, right? So that need to make sense based off your instructions there. And then this is just a point which you probably won't use in my class, but if you ever want someone to specifically get a brand name drug, they say the brand name is the only thing that works for me, and you want to do that, then you have to write DAW, which means dispense as written, or there may be a box on your script box that will have that available. So most of the time, as a financial benefit to the patient, we will sub out generics for the brand names. That is totally appropriate. The generics do work just as well as the brand names. 99 times out, or 999 times out of 1,000, I would say it's totally appropriate to do that. There are some rare instances where not. You can write DAW, and that makes us have to give the patient the brand name. Okay. And so these are some other common abbreviations I'd likely avoid for your purposes there. I did provide a list of abbreviations not to use as stated out by the Joint Commission in the prescription writing assignment, so you can take a look at that. But yeah, those are the things you want to consider avoiding there because it could be mixed up. Okay. Other things too, unless it is a very specific packaging where it gives them all the directions on how to take something like a methylprednisolone dose pack, don't write take as directed, right? Even though you may have told the patient what to take, doesn't mean they're going to remember that, right? So you want to make sure that instructions get put on the bottle. So if you write take as directed for any of my script assignments, you're going to get dinged for that because I want to make sure that you can actually interpret what you're reading in a drug reference and then actually put that down onto paper and something that's appropriate for that patient. Other things too is just being cognizant of contraindications or interactions patients may have either with the drugs they're already taking or other disease states they may have there. Make sure that you get the full medication list for them. What herbals do they take? What OTC drugs do they take? And make sure there's no physiochemical incompatibilities. As I use for example that fluoroquinolone plus calcium they mix together, it renders the fluoroquinolones inert, so you don't want to do that, right? And then again, disease state interactions. You know, if I give someone with diabetes a corticosteroid, it's going to raise their blood sugar and make that more difficult to control, right? We'll learn about those specifics later on, but those are the things you want to think about, right? So I'm probably going to cut it off here. I think, yeah, a couple more slides, but I don't think they're going to be too relevant for our purposes here. So I'll finish that up, and then we'll get into the next section next time. Let me see if there's any questions here on the sticky board. I don't see anything so far. I'm going to check something quickly, though. If you have any questions, go ahead and post them up in the chat box there on the sticky board. I'll look that up. Make sure if your assignment is due this week or not. Yeah, so your prescription assignment is on here, so I'm looking at that now. Put that up. All right, so you can see your prescription assignment. Basically, you'll just go ahead and take the case there. So I believe I updated that, so you should be able to download that and look at that. Again, when you're looking at the blank prescription page, go ahead and write out everything by hand. Even if it's digital, that's fine, and they can then turn that in. I'll make sure the due date is going to be 1 week from today. That way you'll have 7 days to work on that, since we didn't talk about it until today. And yeah, the rubric is pretty straightforward in terms of what I'm looking for. You know, every prescription assignment that I do is going to include at least one pediatric dosing there. So if you run into some issues with that, let me know, and I can go ahead and try to work that through with you. But otherwise, it should be pretty straightforward. All right, so someone's asking here, can you please explain, or not, I guess they didn't say please, so they did at the end there, so it's okay, it's very polite. Can you explain the difference, explain the effects of VD and clearance and half-life again, please? Yes, I will. So when you're looking at, I'll make my own new sticky note. When you're looking at half-life and you're looking at clearance and you're looking at VD, they're all very well interconnected, right? So when you're looking at this, you can see the clearance, or half-life, T1/2 is going to be equal to clearance over that VD, right? So what that basically means is that, and again, remember, think half-life is sort of a backward sort of concept in your mind a little bit. So if I'm clearing the drug very quickly from the body, I'm getting rid of it very quickly, half-life is going to be relatively short. Like that adenosine I mentioned that only had like a half-life of like less than 10 seconds, okay? Versus like amiodarone, very long half-life. It takes forever to get rid of that out of the body. It can stick around for years in some cases, okay? So if my clearance goes up in these cases here, right, you're going to see that I'm clearing it faster. I think I read that right. Let me make sure I read that right correctly there. I don't know to talk too fast and then get myself confused. Yep, I wrote it backwards, my bad. Excuse me. I looked at it and I said, something is not right here, but it's okay. I got it correct now. So, right, so looking at VD over clearance. So this makes sense. So if I have a half-life, and again, looking at how quickly or how slowly I'm getting rid of things. So if I have a larger VD, meaning I have more liters to clear, more volume to clear, that's going to take longer, which means that the higher the VD is, the longer the half-life. So something is particularly lipophilic and likes to go out into the fat, or if I have something that maybe the volume of distribution has increased for. So if I have like a hydrophilic drug and the patient is now very edematous and they have a lot of extra body fluid, that's going to cause VD to go up, and that causes the half-life to increase, right? On the flip side, though, I can have clearance here, which is in the denominator. And what you notice here is that if clearance gets longer, or sorry, if clearance goes down, let's say my kidney function is now decreased, and I'm not clearing the drug as well, clearance has now gone down here, right? So clearance going down in the denominator makes this whole value increase, right? So half-life actually goes up the worse the kidneys are functioning. That's an inversely proportional sort of thing there, as you're going to see with half-life in terms of clearance. Okay, hopefully that makes some sense. But if not, let me know. You can send me an email or something. I can go ahead and check that out. Okay, let's see. Will the content from next week be on the exam next week? I need to double check on that. I thought it was the first 4 weeks. Let me double check on that, and I'll send you guys an announcement. So Worry about that. As a remainder of this PowerPoint going to be on the exam for next week. Thanks in advance. Nothing I haven't covered will be on the exam. Let me double check that. I'll send you guys an announcement. I need to look at the schedule again to make sure everything is good from that standpoint. So, but yeah, for the exam, if it is next week, which I'm pretty sure it is, it's only going to include up to what we covered today. Okay, so I'm not going to include stuff on controlled substances and all of that. So I don't want to have you guys be responsible for things you learned like the day before. That would be pretty rude on my part. So I'm not going to do that. Okay. Let's see. I was already thinking about the exam. Yeah, tests. Yeah, Maggie was asking about that. Yeah, it'll just be the first 3 weeks. Although I'm surprised I didn't do that for 4 weeks, but it's okay. That's what the schedule is, so I'm gonna stick with that. Any other questions I can answer for y'all before I let you go? I'll look at it and post an announcement today sometime, so that way you'll be at ease and know it's on the test. Well, if nothing else, you all are free to go. I hope you have a great week, and if you have any questions or anything, feel free to certainly email me in the meantime, and I will get back to you guys when I can. So otherwise, have a great week, and I will talk to y'all later. Some people just always stick around, just like, wait, maybe someone asks a question. But... Okay, well, I'm gonna end the stream here. If you guys have questions, email me, and I will talk to y'all later. Have a great day.